You can start, Dr. Balian.
Hi, everyone. I'm Dr. Harry Balian, interventional cardiologist, the chair and cath lab director at Adventist Health, Glendale. Today, it's an honor for me to give you guys my talk on updates on heart failure. With that, my objectives are to define heart failure, both systolic and diastolic heart failure, outline the anatomy of the cardiac myocyte, to go over the classifications of heart failure, the treatments, talk about some of the major landmark trials, discuss the new updated guidelines, and also some of the newer medications that are out in the market for heart failure treatment and improvements, and then go into adjunct therapy such as ICDs, transvenous and subcutaneous, and also talk about Barostim device, CardioMEM device, and lastly, lifestyle modification and closing remarks. I'm gonna disclosures none. I'm going to talk about a patient, 78 years old, with CAD, had the stent put in 2 years prior, still smokes, dyslipidemic, diabetic, developed chest pain while exerting in his backyard, was admitted, and he basically came in with the left lower sternum border chest pain. With that, his initial troponins were negative, and a stress test was ordered. In the stress test, he had a stress with a myoview, the nuclear stress test, which showed a defect in the anterior wall. His EKG also showed some changes, namely ST depressions. With the positive nuclear stress test and abnormal EKG, we decided to consider cardiac catheterization. So going through his EKG, he has normal sinus rhythm at baseline, good RV rate progression, and basically no evidence of ischemia. This is his baseline EKG. Chest X-ray is, again, unremarkable, normal cardiac silhouette, and normal lung fields, no evidence of heart failure. The nuclear stress test did show evidence of anterior wall defect, and basically showing that the anterior wall was consistent with inadequate blood flow. The echocardiogram showed normal LV function, this being the septum, apex, and then posterior wall. This is the mitral valve and aortic valve. Again, the septum and anterior apex and the lateral wall both all moving uniformly without any wall motion abnormalities. Cath was proposed and performed. During the catheterization, we're able to find out that his LAD very proximally had a high-grade stenosis, which corresponds with the nuclear stress test showing anterior wall reversible defect. So at this point, we decided to wire both the LAD and the diagonal. The diagonal was ballooned, and both the LAD and the diagonal were stented successfully. And the patient was basically discharged home on DAP therapy, aspirin, and Brilinta, and he was supposed to be taking these for 1 year. Unfortunately, he was discharged home, was not taking his antiplatelets, and about a week and a half later, actually about a week later, showed up to the emergency room, crushing chest pain, and the EKG showed tombstoning pattern, ST elevation consistent with ST elevation MI. More than likely, we suspected that he may have thrombosis stents. As you see the EKG here, the anteroseptal lead has about 3 millimeter ST elevation. The tombstoning pattern with the reciprocal ST depressions. This is classic for a myocardial infarction involving the LAD distribution. And the EKG subsequently got worse. The tombstoning pattern got worse, and this is obviously very, very concerning. Patient was rushed to the cath lab, and sure enough, his LAD stent was occluded 100%, and we're able to wire and do a quick aspiration, atherectomy, thrombectomy, and brought out some clots within the artery, which was directly the cause of him being non-compliant with his medications. And this is his anatomy. As I mentioned earlier, his LAD and diagonal were both stented, and now there was a clot sitting right at the junction, and this was aspirated, and angioplasty was performed. intravascular ultrasound did show that the LED stent was well opposed, so that was not a mechanical issue. It was more of a patient's lack of compliance and pharmacologic issue. So in any case, we had an optimal result after the angioplasty and stenting. However, patient went to flashform edema and had bilateral pleural effusions. He had a prolonged hospitalization where he was diuresed and placed on afterload reduction, and a repeat echocardiogram now showed that his ejection fraction, which was normal at baseline, had dropped to about 33%. So he basically lost a big chunk of his heart muscle, some of which is hibernating, and the other portion was infarcted. And this is basically the echocardiogram showing ballooning of the septum and then the anteroseptal area, consistent with the infarct at the LAD distribution. Now, at this point, we have a patient who came in with a stent and was non-compliant and returned again with a stent thrombosis, and unfortunately sustained a large myocardial infarction. And by the way, the stent thrombosis can lead to 40% mortality. So it's a very dangerous situation when the patient after a stent decides not to be compliant with their medication. So we have a patient now in heart failure, and hence my talk and my lecture is going to focus on how to treat a patient like this in heart failure at day one and moving forward. So what is heart failure? It's a myocardial dysfunction of either a pump failure, whether the pump is failing to contract or relax. So there's two aspects of heart failure: systolic heart failure, where the heart muscle does not contract properly, and diastolic heart failure, where the heart muscle doesn't relax properly. And they can equally be troublemakers and cause comorbidities for the patients. So looking at the overall anatomy of the heart muscle, we have the actin and myosin cells, and when the actin and myosin overlap each other, we have a contracted myocyte, and then that's what causes the systole. The diastole is actually the systole is passive and diastole is active form, meaning you need actual energy to have a relaxation of the heart muscle. And that's one of the reasons why when people pass away, they are in rigor mortis, but they don't have the energy to the ATP to pry the actin from the myosin, and so the muscles stay in a contracted state. So the as I mentioned, actin myosin overlapping causes the contraction. The relaxation is is an active process where calcium enters the cell. Calcium then causes prying of the actin from the myosin, and that's what causes the relaxation. Heart failure can be in different formats. This is a normal heart where the heart looks like a football, ellipsoid shape. You can have dilated cardiomyopathy where the heart is ballooned and all four chambers are dilated. You can have hypertrophic cardiomyopathy where you have the septum or the lateral wall or the apex being sort of thicker than the other parts, and impinging and restricting the LV cavity filling. Restrictive cardiomyopathy also when you have a stiffness of the heart muscle, whether it's an infiltrative process, whether you have any kind of other causes causing the heart muscle to stiffen. Whenever we have our original events, namely the heart attack, the myocyte injury, you have eventually cardiac remodeling, and the cardiac remodeling causes some asymptomatic LV dysfunction. But then you have all the bad actors being triggered, namely the neurohormonal activation, which leads to vasoconstriction, salt retention, volume retention, and then finally you have ventricular remodeling, LV dysfunction, and then finally patient goes into overt heart failure. So it's a multiple step process, and a lot of times it starts from an initial myocyte injury. So when you look at the neurohormonal chart, you have an imbalance of this neurohormonal mechanisms that causing patients to go into heart failure. On the left side, the green is good, the red is bad. So when you have the endogenous compensatory peptides, that's a decrease in salt and fluid retention, decrease in vasoconstriction, decrease in blood pressure, decrease in sympathetic tone. All of those are what we want to keep somebody out of heart failure. The red side is the bad side, where you have the deleterious effect, and this is due to the neurohormonal activation causing the renin-angiotensin cascade, and ultimate end products being aldosterone, causing vasoconstriction, salt and fluid retention, and then increase in blood pressure, increase in arterial fibrosis, and hypertrophy. So the goal is to first, with the beta blockers, dim down the sympathetic overactivation that is sort of initiating this cascade, giving ACE inhibitors or ARBs to suppress the deleterious effects of the renin-angiotensin system. And then now we have basically the sacropudral valsartan, which is the Entresto, which decreases the breakdown of the neprosilin, and then causes basically improvement of the endogenous compensatory peptides, causing decreased salt and fluid retention, decreased vasoconstriction, and then also improvement in the blood pressure. So a combination of beta blockers and also the Entresto, which I'm going to get into, is basically a way to maintain patients out of heart failure. When we look at initial myocardial failure that causes impairment in renal perfusion, and also the distension of the aortic root causes AMP, and then also ventricular distension causing BNP elevation, both of which ultimately can lead to the AMP release and increased sodium reabsorption. When we have activation of the renin-angiotensin cascade, we ultimately have sodium retention and volume retention. Patients can be initially in a compensated heart failure phase, where they have mild or moderate renal impairment, renal perfusion impairment. But when you look at their urinary sodium to potassium ratio, it's more than 1. The end stage of heart failure, which is the most critical stage, when you have a decompensated heart failure patient. These are patients that present to the emergency room, blood pressure is in the 80s, and they're wet. They have bilateral pleural effusions. They have bilateral crackles, and it's very precarious position because these patients need to be diuresed, but their pump is weak, their blood pressure is low. So if you do give them Lasix, first it may not work because their blood pressure is low. They're not going to be actively able to pump enough blood to the kidneys and then be able to diurese. And secondly, Lasix itself can lower the blood pressure further, making the situation even worse for the patient. So those are the patients that need to be initially on some inotropic agents, and then followed up with the diuretics to be able to get rid of the excess fluid. In those patients, when you look at the urinary sodium to potassium ratio, that's less than 1. So looking at the overall cascade, when we have a patient in heart failure, basically you have increased afterload, increased LA pressure. Furthermore, you have distension of the aorta, and all in all, when the LV is not pumping well, when the LV is not pumping well, your aorta is sensing low cardiac output, and this low cardiac output is triggering the brain to release signals and to retain more sodium and more fluid, because the body's thinking that they're in a hypovolumic state because the aortic root distension is less, the pump is weak, it's not pumping enough blood, the cardiac output is low. So the brain is releasing the vasopressin, also it's stimulating the sympathetic trunk, and that itself is through the sympathetic ganglion is triggering the kidneys to conserve more salt and more volume, and making the heart failure situation worse. Also, you have peripheral vasoconstriction to shunt the blood away from the periphery and maintain more of the blood to the heart and the brain. Ultimate end product is you have decreased sodium, solute-free water excretion, and then also decreased sodium excretion, making water retention more and making the heart failure worse. So looking at the epidemiology of heart failure, the prevalence of heart failure with reduced EF is basically getting worse. And then when we look at the numbers, we are, we have almost 8 million Americans aged 20 and older, and this number is only going to increase as time goes along. From 2012 to 2030, we're projecting further increase in the numbers of patients with heart failure. Unfortunately, heart failure diagnosis, DRG, is the most common, and also it's the most burdensome to the economy. And as it is, if somebody presents to the hospital with heart failure diagnosis within 30 days of discharge, the hospital does not get paid for that readmission. So it puts a significant cost burden not only to the economy, cost burden to the hospitals themselves. And not needless to say, it puts patients' lives in danger. So all in all, it's very important to deal with this heart failure and heart failure readmissions in a very organized and efficient manner. Again, as I mentioned, economic and health burden for heart failure, there are approximately 1 million heart failure discharges in the US per year, and this number is increasing as time goes along, and we're not doing a good job in curtailing this heart failure discharges and readmissions. A lot of times when patients are in the hospital with heart failure, they're getting their Lasix and diuretics. Their water retention is basically getting better, but they're not fully treated with their heart failure as they should be. So it's a revolving door. They get diuresed, they feel better, they go home. If you look at their overall volume retention, their wedge pressures are still high, and their heart failure treatments are suboptimal, and that's why they return. They are readmitted. And high hospitalization rates are associated with heart failure, and then mortality is also high when patients are admitted with heart failure. This is sort of a revolving door, as I mentioned, and as time goes along and more admissions with heart failure, patient overall mortality risk increases. It's almost like having a terminal illness when somebody's getting readmitted over and over again with heart failure, and ultimately they're going to succumb to their disease process. This is affecting both men and women, and interestingly, more women than men are being diagnosed with and hospitalized with heart failure. When you're admitted with heart failure diagnosis, your mortality is much higher than if you're admitted with no heart failure. So all in all, heart failure is a bad actor, and that's why we have to pay very close attention to treatment of the heart failure, not only in the immediate sense, but also long-term. And outcomes worsen with each hospitalization. First, second, third, and fourth, the overall outcomes get worse and worse as the patient's hospitalization frequency and number increase. So it's almost like a downward spiral. The more hospitalizations, the higher the chance of morbidity and mortality. The reasons for 30-day readmissions after heart failure discharge, the most common is recurrent heart failure, and other causes could be renal, pneumonia, arrhythmias, sepsis, etc. And again, this is the downward spiral. The more admissions with heart failure, and eventually you have a chronic decline to the point where a patient eventually succumbs to their disease process. It's important to go over this New York heart failure classification, class 1, 2, 3, and 4. 1 being when the patient's walkie-talkie, they have no symptoms with exercise, and no symptoms at rest, minimal to no symptoms with exercise. And class 4 obviously is the worst, where they're very symptomatic at rest, and their exercise capacity is extremely limited. And understandably, the class 4 is the worst. Their mortality is highest if they have class 4 heart failure, and class 1 is the least, and mortality is the least in patients that have NYHA class 1. So we have to pay very close attention to patients that are sitting in the NYHA class 3 and 4, because those are the sickest usually. What are the symptoms of heart failure? Most commonly, they have dyspnea and exertion. They have PND, orthopnea. So it's important to note what PND is. Paroxysmal nocturnal dyspnea is when the patient endorses that they're sleeping, and all of a sudden, in the middle of the night, they get up and they have to sit on the edge of the bed, and they feel like they're choking. And that actually is consistent with increase in their LV and diastolic pressures, and that and causing them to abruptly get up in the middle of the night and having to sit up. And that can be signs of heart failure. That can be also signs of ischemic burden on the anterior wall. When I have a patient that is at risk for high risk for coronary disease and they're complaining of PND, that can tell me that either the patient's heart failure symptoms are worsening or they have worsening ischemic burden, and that they should be then evaluated at least with either a stress test or a cardiac catheterization. So those are essentially some of the major signs of patients coming with heart failure. As far as the physical signs, when you look at the patient with heart failure, you would see a JVP, the jugular venous distension. When you lay the patient supine at a 30-degree angle, you're able to sort of draw a line from their sternum all the way to their neck at an angle. If the JVP is, you can measure from that line up to the neck. If the JVP is more than 3 centimeters, that basically tells you that patient is in fulminant overwhelming heart failure. They have high volume retention, decreased cardiac output. They also can have the parasternal lift when you checking their PMI, point of maximum impulse on their heart. They can have a parasternal lift. They have also apical impulse where their heart's dilated and you're able to feel that apex beating all the way to the end of their chest cavity. You can notice extra heart sounds, namely the S3 and S4. So when you look at the heart sounds, we have S1, S2, S3, and S4. S3 and S4 normally are not palpable, and they're usually can be pathologic. S1 is when you have a closure of the mitral and tricuspid valve, and it starts, it basically signals the beginning of systole. That's when you have an isovolumic contraction of the left ventricle, and then to the point where now the aortic valve and pulmonic valve open, and then the heart is, the blood is ejected out, and then eventually the aortic and the pulmonic valves close, and that's an S2, and that marks the end of systole. Now S3 and S4 are diastolic heart sounds. S3 happens at the beginning of diastole, and S4 is towards the end of diastole. When you have S3, it means that you have a stiff ventricle, and when your mitral valve opens at the beginning of diastole, you have passive filling of the left ventricle, and when you have a stiff left ventricle, you have a S3. It makes a S3 heart sound because the passive blood is filling from the left atrium to the left ventricle, hits a stiff left ventricle, and makes an S3 heart sound. This is during beginning of diastole. S4 is towards end of diastole, when you have basically your LV, most of the LV being filled by atrial contraction. Normal LV should be filling passively, but when you have a stiff LV, you are force feeding the left ventricle through atrial contractions, and that the atrial contraction force feeding the left ventricle makes an S4 heart sound. S4 is consistent with a thickened, stiff left ventricle and the force feeding of the left ventricle towards the end of diastole via atrial contraction. The reason that patients who have LVH and who have diastolic dysfunction, they become very sick when they lose their atrial kick and they go from sinus rhythm to atrial fibrillation, is because they lose their atrial kick and then they lose the ability to fill their left ventricle, and they're pretty much dependent on the late diastolic filling of the left ventricle. And when the sinus rhythm goes away, the atrial contraction goes away, they become essentially disabled in adequately filling the left ventricle. That's why they become hypotensive. And we see these patients, they come in, their blood pressure is in the 70s, they're in rapid AFib, and you put the echo probe on their chest, their left ventricle is actually very forcefully contracting. They're not cardiomyopathic, but they're hypotensive because now they've lost their ability to fill their left ventricle during diastole. So what are some of the causes of left ventricle dysfunction? So coronary disease is one of the major causes. When you have coronary disease, your heart muscle becomes stiff. You become your ability to passively fill the left ventricle is disabled. Also, when you have coronary disease, you also have LV dysfunction, and then your systolic function is impaired. So you have systolic dysfunction and diastolic dysfunction. That can also cause, incidence of systolic and diastolic heart failure. Metabolic causes, some of the vitamin deficiencies can cause heart failure. Neurologic causes, Duchenne's and some of the muscular dystrophies. Heavy metals, when you have hemochromatosis, some of the other infiltrative diseases such as amyloidosis, sarcoidosis can cause heart failure. In fact, amyloidosis, a classic picture is African-American woman with a low voltage EKG presenting with heart failure. And then on the echocardiogram, you see the speckled pattern, which is the starry sky pattern. And that's a sort of a classic picture of amyloidosis. Other reasons when you have sarcoidosis, this is a lot of times patients that present, young patients less than 60 years of age, that present with new onset heart block or arrhythmias, and then you do the workup and you see infiltrative disease and sarcoid in their left ventricle. Inherited diseases, some people have a genetic predisposition to having heart failure, and then this is usually this comes about postpartum or peripartum, and then also at a young age they have incidence of heart failure. So when you sometimes you see African-American young men, they come in their 30s and 40s, they have cardiomyopathy, heart failure, hypertensive heart disease leading to heart failure. Also, you see young women postpartum after their first delivery, they have severe LV dysfunction, heart failure, and then you do a little bit of further digging in, and you sort of see that they have had familial history. Parents have had a premature onset of heart failure, etc. Infections, HIV, some of those other viral infections can cause heart failure, some of which can be really strenuous. People coming in with a simple virus that affects the sore throat, then eventually can have a fulminant heart failure to the point where they overtly cardiomyopathic, multiple pressor dependent, and we've had patients actually that we have to fly them to a tertiary care center. They have to be in ECMO, where they need full support of their heart because their EF is dropped down to like 5%, and they would otherwise be dead very shortly if they don't have that full cardiac support. Some of which make a full recovery, others may need a heart transplant. Drugs can cause heart failure. We call the holiday heart syndrome. Usually patients that are drinkers, they become cardiomyopathic, they go into atrial fibrillation. Cocaine and crystal meth, all of those, you see the young people on crystal meth with low ejection fraction because they have burned out hearts from the drugs. When you take a sample of the population, 3% of the population walk around, they have low ejection fraction. The other 97% have normal. Out of the 3%, they have low ejection fraction. Half of them are symptomatic. The other half are completely asymptomatic. So I already sort of went over this, the different causes of heart failure. And again, infiltrative disorders, amyloid, hemochromatosis, nutritional deficiencies, protein, thiamine, selenium, etc. Tachycardia-induced cardiomyopathy, patients that have overt rapid AFib, and eventually their EF drops because they're literally, it's almost like they're on the treadmill consistently for days and days. Eventually their heart fatigues. So how do we start with a diagnosis of heart failure? History is most important. Talking to the patient, looking at their onset of symptoms, basically, how long have this been going on? When did it start? Have they been putting on weight? And by that I mean every 2 days they're gaining 3 or 4 pounds without really excessively eating. That would give you a sign and a clue that patient is having water retention. So when I deal with patients with heart failure, I make a concerted effort to tell them to weigh themselves daily. If they put on a couple of pounds overnight for no reason, that's a sign that they're retaining volume, they're slipping back into heart failure. And that's when they know to take an extra dose of Lasix, for example. And that in itself can keep them out of hospitalization when they're able to recognize the signs early on, and they're able to be proactive about it to keep themselves from being admitted with heart failure. Also, the decreased urine output, the patient will say, I stopped urinating, I'm making very little urine and the urine color is very dark. That tells you that patient's slipping into heart failure, the heart muscle is not pumping enough blood to the kidneys, and then the kidney urine output is basically very low, and the urine color is very dark. When we look at these patients with heart failure, obviously, physical exam, you have bilateral crackles, you have the bipedal edema, JVD, increased apical impulse, and maybe listening to an S3 heart sound. An EKG is performed, and the EKG, if they have chronic signs of cardiomyopathy, you're going to have biatrial enlargement. You're going to see widened QRS, the electrical signals. If they have underlying hypertrophic cardiomyopathy, you will, and subsequent heart failure, you can see voltage gain. And if you have other infiltrative causes such as amyloidosis, etc., you can actually see voltage loss and low voltage EKG with heart failure symptoms, and an echo pattern of that starry sky, as I mentioned, can be consistent with amyloidosis. Of course, that's the workup for that is a whole sequence of steps such as getting a technetium pyrophosphate scanning, checking the blood test, ruling out other causes of amyloidosis, and then also checking for the ATTR amyloid, which is a cardiac involvement pattern. This is an EKG of a patient with right atrial enlargement, and the reason that and it has heart failure symptoms, and you have this Himalayan P wave, and also upright P wave in V1, peak P wave in lead 2. Though that's classic sign of right atrial enlargement. So when you look at this atrial size, you just pay attention to lead 2 and V1. And lead 2, if you have peak P wave, that's a sign of right atrial enlargement. If you have notch P wave, and sort of if you draw this little circle and then say half of the circle is the right atrium, the other half is the left atrium. If you have a right atrial enlargement, you're going to have a peak P wave and then a very small notch on the left atrial side. That the summation will give you a tall P wave in lead 2. This V1, half of it being right atrial component, the other half left atrial component. Usually you would, if you have a very pronounced right atrial enlargement, you're going to have tall P wave and then very little left atrial size. So that summation will be upright P wave in lead V1. If you have left atrial enlargement, as I mentioned, you're going to have a smaller P wave peak for the right atrial component, very tall P wave in the left atrial component, meaning total you get a notch P wave in lead 2. And then you're going to have a small P wave in the right atrial component and a flip P wave in the left atrial component. You're going to have a summation of flip P wave in the V1, and that will tell you have a left atrial enlargement. So this is a patient with left atrial enlargement. You have a notch P wave in lead 2 and then a flip P wave in lead V1. So what else can we use to diagnose heart failure? The beta natriuretic peptide is actually very important. It's released by the ventricular stretching, whether it's RV or LV. When you have a shortness of breath and somebody comes in with elevated BNP, we can pretty much conclude that the shortness of breath likely is coming from stretching of the ventricle. Whereas if you have patients coming in with shortness of breath and they have a normal BNP, you can make a conclusion that this might be a cause of like COPD exacerbation and due to the lungs rather than heart failure. The ranges of the BNP normally should be less than around 200, but when you have a BNP upwards in 1,000 plus, that's obviously very abnormal. Some of these medications, ephedra, anthracyclines, alcohol, cocaine can actually lead to heart failure, as I mentioned. So you have to be very cautious with these medications. Some of the cancer drugs, Herceptin, can cause heart failure. So when somebody's being initiated on cancer therapy, we need to do a echo ahead of time. We can also consider doing a MUGA scan to see if their overall ejection fraction what it is at baseline, and then if there's any drop in their ejection fraction subsequent to the institution of the cancer drugs. If you have a drop of ejection fraction more than 10%, and with the subsequent cancer drug administration, you have to basically let the oncologist know about the drop and then possibly stop the medication. If the ejection fraction of the baseline is low, in the 30s, and you have a drop of the ejection fraction more than 5% in the subsequent administration of the cancer drug, again, that has to be sort of a red flag that the cancer drug is actually causing worsening cardiomyopathy and becoming cardiotoxic. Sleep apnea is a lot of times under-recognized that it can cause heart failure. Sleep apnea is a bad actor and basically patients are stopping their breathing process multiple times a minute, and that is causing desaturation, abnormal electrical EEG waves, and sudden rise in the blood pressure, and then also episodes of tachycardia. So if you have sleep apnea that's untreated, the next day patient is like a zombie. They have narcolepsy where they're falling asleep, involuntarily. They feel very foggy headed. Also, the physiologic changes of sleep apnea, they can cause thickening of their vessels, pulmonary hypertension, uncontrolled hypertension, and possible LVH and some arrhythmia. So sleep apnea is very important to recognize and treat. So patients need a sleep study and also probably need to be on that CPAP machine. Unfortunately, the CPAP machine is like a lot of patients complain that they feel like they're being choked, but there are different masks, the ones that you can wear around your ears, the ones that are not pressing on your nose and pressing on your face. So there's variations of that. So that is something that could be tailored with the primary doctor or the pulmonologist to be prescribed. So management of heart failure, we have to make sure first and foremost, when somebody comes in with heart failure, you have to diagnose. First, the diagnosis entails looking at it and seeing whether this is systolic or diastolic heart failure. In the acute setting, you need to unload their excess fluid. So Lasix would be in the immediate setting, diuretics would be the immediate savior to unload them. If they're hypotensive and in a volume overload, we need to give them some level of inotropes to be able to increase the blood pressure enough that the heart can pump the blood to the kidneys, and then patient can then diurese appropriately. Then obviously we have to deal with the other consequences of the heart failure, the neurohormonal activation, and there's medications to essentially counteract that. The sympathetic overactivation, there's medications to counteract that. So beta blockers, as I mentioned earlier, will counteract the sympathetic overactivation. The ACE and ARB or possibly the sacubitril with the ARB, namely the Entresto, causes decrease in the neprosilin inhibition, and basically you have more of the endogenous peptides that actually cause that counteract the deleterious effects of the neurohormonal overactivation. So looking at the renin-angiotensin cascade, you have angiotensinogen being produced from the lungs, the renin being produced from the kidneys. Angiotensinogen is converted to angiotensin 1. Angiotensin 1 is converted to angiotensin 2, and eventually this goes to the receptors, and then the end product is aldosterone, which actually causes vasoconstriction, decreased sodium excretion, and increased volume retention by the kidneys. The ACE inhibitors block angiotensin 1 to 2 conversion. You have angiotensin receptor blockers, which actually block the receptors and lead to less release of the aldosterone. And then you also have blockers of the aldosterone that also work in a fashion where you have decreased vasoconstriction, decreased sodium retention. So this I mentioned, when somebody comes in with acute heart failure, you need to diurese, stabilize the blood pressure. If you need vasopressors, then they need some inotropes to be able to increase the blood pressure so they can diurese. Ultimately, for the long-term maintenance, beta blockers should be considered, but not in the acute setting, because beta blockers will cause further decrease in the inotrope of the heart, and if the patient's already cardiomyopathic, acutely giving him beta blockers may make the situation worse. Digoxin, again, there's isolated studies seeing that digoxin causes less hospitalization but does not improve mortality. And then other treatments, which I'm going to go over, the aldosterone, and also if somebody has persistence of the heart failure, low ejection fraction, consideration of ICD. So the first line treatment diuretics, consider the digoxin, ACE or ARB, or the Entresto. If you're giving Entresto, then ACE and ARB should be discontinued because Entresto does have ARB in it. So the diuretics in themselves for the long term can cause deleterious effects, namely, hypokalemia and decrease in worsening renal dysfunction. So those are, and then it can make the neurohormonal overactivation worse. Beta blockers in the immediate setting should be we should be wary of giving patients beta blockers if they come in with decompensated heart failure. But in the long term, as I'm going to show you the data, it's been shown that tremendous benefits because they basically dim down the sympathetic overactivation, which actually improves heart failure symptoms and improves patient's ejection fraction. Be also careful if somebody has overt bronchospasm, overt bradycardia, overt depression. Beta blockers should be avoided in those patients. But again, looking at baseline beta blockers in the baseline when patient comes in with heart failure with low EF, that would be probably not a good idea. But looking at beta blockers to be given after patients diuresis and euvolemic further out, 1 month out, 3 months out, you see tremendous benefit of beta blockers. And some of the major studies, such as the Carvedalo trial, the Merit HF, Copernicus trial, and CIBIS-2, all show improvement in mortality in patients that have been maintained on beta blockers and decrease rehospitalization with heart failure. So beta blockers in the long term are very essential in treatment of heart failure and improvement of ejection fraction. Adjunctive treatments to heart failure, also ACE inhibitors, has anti-ischemic benefit, reduced risk of initial myocardial infarction, reduced risk of recurrent myocardial infarction. And ACE inhibitors, as I mentioned, decrease the conversion of angiotensin 1 to 2. And subsequently, you have increased bradykardia, which actually leads to increased nitric oxide. So again, ACE inhibitors are a good drug, but 30% of patients taking ACE inhibitors have this dry cough. So that's one of the common complaints of patients on ACE inhibitors. The ELITE, CHARM, SOLVIT consensus are some of the major trials looking at the benefit of ACE inhibitors versus placebo. And all 4 trials shows a statistically significant reduction of mortality and also reduction heart failure admissions. So again, ACE inhibitor is very important in the treatment and maintenance, treatment of heart failure and keeping patients out of the hospital. The worsening renal dysfunction during initiation of heart failure therapy, it's a known fact that ACE inhibitors and ARBs can initially increase creatinine. So less than or equal to 30% in creatinine rise may be expected. Also, they can worsen hyperkalemia. If somebody has a potassium already around 5 and you start them on ACE or ARB, their potassium are going to go up, and that obviously can be dangerous in somebody with hyperkalemia and heart failure. They may have a low ejection fraction, and they may be prone to having ventricular arrhythmias. So in lieu of the ACE or ARB in somebody with hyperkalemia, a combination of hydralazine and nitrates should be considered for afterload reduction. And that actually works equally well in somebody that needs afterload reduction for heart failure and they're hyperkalemic and cannot tolerate the ACE or ARB, as I mentioned. So the digoxin, I'm just going to say a couple of words. It's not a common line therapy anymore, but the digoxin does improve or decrease the heart rate without affecting blood pressure, and also keeps people out of the hospital, but it does not change mortality. So the DIG trial showed that there was a decreased hospitalization rate in patients with heart failure that were started on digoxin, but there was no change in the mortality. Furthermore, Radiance trial showed that with the patients who were on digoxin, there was a decrease in the probability of worsening heart failure. The effect of aldosterone antagonism on mortality, again, there's the aldosterone antagonists, such as the aldosterone, spironolactone, eplerenone, the reduced myocardial fibrosis, reduced renal damage, reduced vascular damage, improved endothelial function, all of those. And the RELS, epiphysis, and TopCat trial are the three trials studying aldosterone versus the placebo, and showing that there was an improvement in survival of the aldosterone versus the placebo, and the study was up to 36 months out. So when we look at the heart failure, where do the medications work? So beta blockers work on dimming down the sympathetic overactivation, which is seen in patients with heart failure. The renin-angiotensin cascade, RAS inhibitors such as ACE/ARB, aldosterone antagonists, and the Entresto work on this level. There's also the IFR channel blockers, which actually don't change the blood pressure, don't affect blood pressure, but they do decrease the heart rate in patients that have this overactivation and tachycardic response in the setting of heart failure. So this study published in New England Journal in 2014 showed the efficacy of Entresto versus ACE inhibitors in heart failure, and looking at 914 patients in the Entresto arm and 1,100 patients in the ACE arm. And overall, it showed that basically patients that were on Entresto, this is a light blue, had the lower number of events versus ACE inhibitor, and lower number of heart failure events, lower number of rehospitalizations. So it basically showed that the Entresto had the statistical significant benefit over ACE inhibitors in the treatment of heart failure and keeping patients out of the hospital. And this is the Paradigm HF study that looked at Entresto versus ACE inhibitor in treatment of heart failure and hospitalization for heart failure. And the clinical progression analysis, time to first occurrence of hospitalization within 30 days was lower in the Entresto arm versus the ACE inhibitor arm. And as I mentioned, when you give somebody Entresto that does have a valsartan in that mix, you would have to discontinue ACE or ARB. You don't want to double dip giving them ACE or ARB plus Entresto. That would be contraindicated. In the same way that we would be wary of giving patients ACE or ARB in the setting of hyperkalemia, you have to also be careful not to give these patients Entresto because it has a valsartan component. It can also worsen hyperkalemia. Another note is the Entresto can lower the blood pressure. If somebody are already hypotensive at baseline, taking Entresto, which is a BID dosing, can worsen the hypotension. So that's something that they have to walk that fine line and make sure that patients are not overly hypotensive, or they're not terribly symptomatic after being initiated on the Entresto. And the dosing starts in the 24, 26, and then goes to 49, 51, and it can go to even the higher dose. Summary showing Entresto is a combination of a neprilysin inhibitor and an ARB, indicating the reduction of risk of CV death, hospitalization for heart failure in patients with chronic HFrEF. It's superior to ACE inhibitor in reducing risk of combined endpoint of CV death or hospitalization for heart failure. And the most common adverse reaction were hypertension, hyperkalemia, cough, dizziness, renal failure. So the Corlanor is the medication that works on that funny channel, IFR, where it acts on the SA node, does not reduce blood pressure. If somebody has low EF and they're already normotensive to hypotensive at baseline, and they're tachycardic, giving them that Corlanor actually works well to reduce their heart rate without affecting their blood pressure. In the SHIFT study in Europe, reduced hospitalization for worsening heart failure or CV death in patients that were on Corlanor versus placebo. I want to shift gears and talk about other adjuncts that are being used to treat in the treatment of heart failure. And interestingly, those medications initially have been used for treatment of diabetes. And as a side note, we were able to see that not only there was decreased glucose retention in the kidneys, but also there was decreased sodium retention and subsequently decreased water retention. So incidental finding of these diabetic drugs were not only we have lowering of the blood sugars and A1C, but also we have improvement of heart failure symptoms. So the SGLT2 inhibitors are basically FDA approved for use with diet and exercise to lower blood sugar. but now also being used as an adjunct in treatment of heart failure, and they're incorporated in our revised heart failure guidelines, which were published last year. The three major ones are the canagliflozin, dapagliflozin, and empagliflozin. Namely, the three main ones are the FACC, Jardiance, and also the lexicon. And I'll give you the further data on this one. So the FACC and the Jardiance are the SGL2 inhibitors. It's expressed in the SGL2 receptors are expressed in the proximal renal tubules, leading to reabsorption of filtered glucose from the tubular lumen. When you inhibit the SGL2, you basically reduce the reabsorption of glucose, and you have promotion of glucose excretion. Subsequently, you have a reduction in sodium reabsorption and increased sodium delivery to the distal tubule, so more sodium is excreted, and patient has less volume retention, thus improvement of the heart failure symptoms. So you have improvement of glycemic control, but also you have improvement of volume retention and heart failure symptoms. So looking at FARXIGA, which is again an SGL2 inhibitor, you have decreased glucose and sodium reabsorption. You have increased sodium to the distal tubule, so more sodium is delivered, more sodium is excreted from the kidneys, more glucose is excreted, and they have less volume retention. Ultimately, you have improvement of the heart failure symptoms, improvement in glycemic control as well. Furthermore, you have downregulation of the elevated sympathetic activity, and you have decreased pressure under which the heart is filling, so namely decreased preload and decreased afterload. The outcome being decreased heart failure symptoms in patients with diabetes and multiple cardiovascular risk factors. So this is one of the reasons why SGL2 inhibitors now have been incorporated in the guidelines in the treatment of heart failure in HFrEF patients. 10 milligrams is the recommended dose, and it's contraindicated in patients that are undergoing dialysis and or GFRs are less than 25. So there's some FDA warning of rare occurrences of serious infection in the genital area in patients with SGL2 inhibitors for diabetes. So you have to be careful with that one. INPEFA, basically, this is the sotagliflozin made by Lexicon. And this is the medication that is a SGL1 and SGL2 inhibitor. It's expressed in the renal proximal tubule, and it leads to reabsorption of glucose and sodium from the renal filtrate. So it's similar to the SGL2 inhibitor, but this also hits SGL1 receptor as well. So it hits both receptors instead of one. SGLT1 is expressed in the kidney, intestine, heart, and vascular endothelium, and it's a primary transporter for absorption of glucose in the GI tract. So SGL1 inhibition delays the absorption of glucose, lowers postprandial glucose and insulin, and may result in mild to moderate diarrhea in some of the patients. When we hit both receptors, so we inhibit both receptors, you have less glucose delivery to the, you have less glucose absorption, I should say, both in the gut and also in the renal tubules. So more excretion of glucose, more excretion of sodium, less volume retention. So the code word that I'm supposed to mention is water. Again, the code word for this talk is water. So the INPEFA indication is for the reduction of cardiovascular death in hospitalization for heart failure and urgent heart failure visit in adults. This is sort of the indication for this SGLT1 and 2 inhibitor. So looking at the one of the major trials, they looked at patients with worsening heart failure and also with chronic kidney disease and SGL1. I mean the INPEFA versus placebo. You had an improvement in overall hospitalization, reduction in hospitalization, and reduction in heart failure symptoms of the INPEFA versus the placebo, and this was statistically significant. So I'm going to talk about the Jardiance, which is a SGL2 inhibitor, and some of the one of the trials for the Jardiance was the EMPA-REG outcome. It's a randomized double-blinded trial looking at placebo versus Jardiance at the lower dose and the higher dose, and the primary endpoint being CV death, non-fatal MI, and non-fatal stroke. Overall, Jardiance versus the placebo showed a reduction in overall CV death, and both at the lower dose and a higher dose, and also improvement in heart failure hospitalization in these patients. So you have, again, reduction in MACE, reduction in CV death, and heart failure in these patients. In conclusion, the Jardians showed a total clinical benefit among patients hospitalized with heart failure across the entire range. And so it showed the benefit not only in reduction of CV death mortality, CV MACE, CV death, and also heart failure admissions. There's a new drug also that is in the market for heart failure, and it's called the Verquvo. And basically, this is for the treatment of heart failure. It comes in different doses, 2.5, 5, and 10. And it works a different mechanism. Its mechanism of action, it's employing basically the mechanism of action is it results in smooth muscle relaxation and vasodilation, leading to it works on the cyclic GMP. So the Verquvo drug basically works on the cyclic GMP, and leads to overall vasodilation, improvement in heart failure symptoms. Heart failure is associated with low nitric oxide and decreased cyclic GMP activity, and reduced cyclic GMP synthesis. So this leads to ventricular vascular dysfunction and MI. When you actually work on Verquvo, actually improves the cyclic GMP and overall leads to smooth muscle relaxation, improves overall nitric oxide production, and it leads to relaxation, vasodilation, improves cardiac function, improves heart failure symptoms. So again, Verquvo directly stimulates the cyclic GMP independently and synergistically with nitric oxide, produces more cyclic GMP, leading to smooth muscle relaxation and vasodilation, improving cardiac function. So these are all some of the new drugs in the market. Obviously, important to make use of somebody's overwhelming heart failure. Initially consideration of first the diuretics and afterwards beta blockers, then the Entresto and the adjunct of the SGLT 1 or 2 inhibitors or both, and then subsequently the Verquvo actually is the one that improves the cyclic GMP, and nitric oxide leads to smooth muscle relaxation and improvement of heart failure symptoms. And looking at the studies here, patients on placebo versus Verquvo, there was a absolute risk reduction of 4.2% in patients on Verquvo, and the number needed to treat was 24 for 1 year to prevent 1 CV death in heart failure patients. And again, looking at the mechanism, heart failure, you have endothelial dysfunction, inflammation, and Verquvo overall enhances nitric oxide, cyclic GMP, and causes vasodilatory properties, smooth muscle relaxation, and heart failure improvements. So a couple of words on the updated heart failure guidelines, which were published last year. And looking at class 1, class 2A, class 2B, class 3. Class 3 is basically contraindicated. Class 1 is indicated, strong indication, and class 2A is moderate indication where the benefit outweighs the risk. So looking at the initial classification of HFrEF, EF less than 40%, and subsequently the modification of this classification where they look at HFrEF and divide it into LVEF less than 40, and the LVEF between 40 to 50. This is that intermediate zone, and then the HFpEF is when the EF is more than 50%. So they basically have the HFrEF, and then they have the intermediate zone, and then they have the HFpEF, which is the EF more than 50%. So looking at patients and the recommendations for renin-angiotensin system inhibition with ACE or ARB, it's a class 1 indication in patients with HFrEF in NYHA class 2 or 3, and symptoms of the use of these medications are basically recommended to reduce morbidity and mortality. This is a class 1 indication. In patients with HFrEF with current or previous symptoms, basically beta blockers are also recommended as a class 1 to reduce mortality, bisoprolol, carvedilol, etc. And recommendations for mineralocorticoid adjuncts is for patients with HFrEF, NYHA class 2 to 4 symptoms using the aldactone or eplerenone, which is the aldosterone inhibitors, is recommended as a class 1 to reduce morbidity and mortality if the estimated GFR is more than 30. Now, recommendations for use of SGL2 inhibitors, such as the Jardiance, Farxiga, or Inpefa, it's patients with class 1 inhibitor, a class 1 indication, I should say, in patients with symptomatic chronic HFrEF. The SGL2 inhibitors are recommended to reduce hospitalization for heart failure and cardiovascular mortality, irrespective of the presence of diabetes. So whether the patient's diabetic or non-diabetic, if they're HFrEF and they're in heart failure, SGL2 inhibitors are recommended. So looking at the overall HFrEF stages, you have step 1, establishing diagnosis of HFrEF, and basically you look at their ejection fraction. If their EF is less than 40, you need to establish a diagnosis whether this is ischemic or non-ischemic cardiomyopathy. So this is when coronary evaluation is actually must. You need to see if the EF drop is secondary due to multivessel coronary disease, or do the patients have what's called non-ischemic cardiomyopathy, where they have patent coronaries, but you have a heart muscle disease rather than coronary artery disease. So once that's established, and patient has ischemic or non-ischemic cardiomyopathy. If it's ischemic, then you have to obviously address the ischemia component and consider revascularization therapy. If they're non-ischemic, then you have to still push for the medical therapy and follow these patients up to 3 months out and reassess their ejection fraction. If their EF is still low, then consideration of adjunctive therapy such as an ICD should be a must, because low ejection fraction basically leads to poor prognosis, namely heart failure and sudden death. So looking at the HFrEF patients, the EF less than 40%, ARNI is indicated in NYHA class 2/3. Otherwise, you consider ACE/ARB in these patients. Beta blocker is a must. Aldosterone inhibitors are a must. SGL2 inhibitors should be considered, and then diuretics as needed. So if you have persistence of HFrEF and EF stays poor, consideration of ICD or BIV ICD should be considered in these patients. And if it still persists, then these patients should be considered for heart transplant. Obviously, if they're not a candidate for heart transplant, palliative care evaluation should be considered. The patients in between the HFrEF and the HFpEF, the EF 41 to 50%. So class 2A indication on these patients with SGL2 inhibitor. So if their EF is less than 50, above 40, consider Farxiga, Jardiance, or Inpefa, and that for decrease in heart failure hospitalization. So these intermediate patients between 41 to 50% EF, diuretics initially as needed, the SGL2 inhibitors, or ACE, ARB, or ARNI, such as the Entresto, the aldosterone antagonists, all of these medications should be considered. So if you're giving ARNI, don't give ACE or ARB. If you're giving ACE or ARB, don't give ARNI. But adjunct therapy of diuretics initially, SGL2 inhibitors, the ARNI, namely Entresto, the aldosterone inhibitors, all of those should be part of the regimen in patients that have this symptomatic heart failure in the intermediate zone between EF 41 to 49%. The HFpEF are patients that have preserved ejection fraction and heart failure symptoms. Class 2A indication on these patients also with the SGL2 inhibitor. It can be beneficial in decreasing heart failure hospitalization and cardiovascular mortality. So in the HFpEF arm, again, diuretics, SGLT2 inhibitor, consider ARNI, such as the Entresto, consider the aldosterone antagonist, or consider the ARBs. Now I want to shift gears and talk about diastolic heart failure. And diastolic heart failure basically is the situation where you have decreased in relaxation properties rather than the contraction. So those patients usually have preserved ejection fraction, but they have a hypertensive heart disease. They're older. They're a lot of times they don't have much of the coronary disease because that portends a lot of times systolic heart failure, and more likely to female gender in these patients that have the diastolic heart failure. Overall, their ejection fraction is preserved. So these patients with HFpEF, diastolic heart failure, they have diastolic dysfunction. They have impaired relaxation and reduced compliance of their heart muscle. So the heart muscle contracts well, but does not relax well. And again, all of these fibrosis, cellular disarray, hypertrophy, asynchrony, abnormal loading, all of those can cause increased passive chamber stiffness, decreased relaxation, and diastolic dysfunction and diastolic heart failure. Looking at this overall diagram, this is a normal patient with a normal heart function where you have what's called an E/A ratio, should be 1.2. This is the relaxation, passive filling of the heart. This is the active filling of the heart. Usually the passive filling should be taller than the active, but as the patient LV becomes more stiff, the passive filling becomes less pronounced and the active filling towards the end of diastole is more pronounced, and you have what's called E/A reversal. A lot of times in the echocardiogram reading, we are told patient has E/A reversal where the E wave is shorter than the A wave, and then you have this reversal, which basically is consistent with diastolic dysfunction and the stiffness of the ventricle. Ultimately, when that continues, then you have basically pseudo-normalization pattern, restrictive filling where the E wave is very peaky, and then you have this fixed restrictive pattern where you have basically irreversible changes of the stiffness of the heart and end stages of the diastolic dysfunction, diastolic heart failure. Atrial fibrillation can potentially lead to some components of diastolic heart failure where you have normal LV function, impaired filling of the left ventricle. Diastolic heart failure patients are more of the elderly, more women, history of hypertension, and they present with heart failure symptoms. And underlying coronary disease, usually those patients are less likely to have advanced coronary disease, more likely to have hypertension. BNPs are usually lower in diastolic heart failure patients than the systolic. So I want to mention about patients with heart failure, the systolic heart failure, low ejection fraction. If after 3 months of aggressive therapy, if their ejection fraction still stays less than 35 or 30%, we need to consider defibrillators on these patients because they can have sudden death. Reduced LV ejection fraction remains the single most important risk factor, overall mortality and sudden cardiac death. In people diagnosed with heart failure, sudden cardiac death is 6 to 9 times more occurrent than in the general population. And so those patients with heart failure, their survivability is lower as time goes along because they die of sudden death. So SCD, the defibrillator therapy is a must. It's important to consider that because it's a lifesaver. Prime example, my grandfather had a heart attack. His ejection fraction was 25%. Unfortunately, his cardiologist never made the attempt to put that defibrillator. And 6 months after his heart attack, he had a VFib event in his bed, and by the time paramedics got to him, they shocked him out of it. He was already brain dead and he passed away. So heart failure and sudden cardiac death go hand in hand. When your ejection fraction is low, your risk of having sudden death is high. So after 3 months of aggressive therapy, if the EF still stays low, you need to be heavily considered for defibrillator therapy. So this is a defibrillator. It acts both as a pacemaker and a defibrillator. It's placed under the pectoralis muscle. It has a lead in the right atrium and a lead in the left ventricle, in the right ventricle. and it detects any arrhythmias. It can pace the heart. It can also shock the heart. In patients that have widened QRS, you have an extra lead that goes into the coronary sinus, which goes right on top of the LV. So you have basically three leads, and that is helps with the resynchronization therapy. It helps narrowing of the QRS, helps patients with their overall heart failure symptoms when you have that extra lead in the coronary sinus. Also, there are defibrillators now that are leadless, and they're placed subcutaneously in the lateral chest, and detects arrhythmias and shocks the patient. Does not pace but shocks. And for patients that are younger, they don't want leads in their heart. There would be those are and they don't have any heart block or any AV nodal disease. Those patients should be qualified for the subcutaneous defibrillator. Having a defibrillator, having a pacemaker, having leads across the tricuspid valve essentially destroys the tricuspid valve in time. People that have pacemakers for years and years, they develop tricuspid regurg and then sort of a degeneration of the tricuspid valve to the point where they need tricuspid valve clipping or tricuspid valve replacement many years out. So that's one of the pitfalls of having defibrillator with leads or pacemaker with leads. So class 1 indication for ICD therapy, cardiac arrest due to VFib or VT, spontaneous sustained VT in association with structural heart disease, syncope of undetermined origin with clinically relevant hemodynamically significant sustained VT or VF, and not sustained VT with coronary disease. So people in ICD higher survival and overall did better than patients that are optimal medical therapy. So this is the matter two conclusions. ICD therapy improves survival when added to optimal medical therapy compared to medical therapy alone. ICDs reduce mortality by 31% in patients with EF less than 30%, and all subgroups showed consistent results regardless of age, NYHA class, EF, or QRS width, or gender. So the subcutaneous ICD, as I mentioned, is leadless. It's placed on the lateral edge of the chest, and basically the lead is overlying the chest. It's not inside the heart. It doesn't go across the tricuspid valve, doesn't destroy the tricuspid valve, and it still shocks but does not pace. So this is basically the leadless ICD that patients can have. This is the leadless pacemaker. That if they need pacing, they can have a leadless pacemaker inside the right ventricle. If somebody comes in with a heart failure or somebody comes in with MI, they have low EF, they have sustained arrhythmias, and they don't yet qualify for the ICD, you can have them wear this life vest, which is sort of a external ICD. The life vest detects actual arrhythmias and it shocks the heart. If patients are in transition between having to eventually need an ICD, but they don't yet qualify because it's been less than 3 months of their initial onset of event, and we're still trying to maximize their medical therapy and reassess their EF, the life vest can be a lifesaver. I mean, I've had patients with cardiomyopathy. I have a young gentleman, 29 years of age, with an EF of 9% due to crystal meth. He had an ICD which got infected because he kept on using drugs. His ICD was taken out, and we had a life vest on him until his infection healed, and we can reinsert a new ICD. And of course, he decided not to wear his life vest, and he went to sleep at night, went into VFib arrest, and passed and died. So this is basically a tragedy, and life vest can be a lifesaver. The Barostim device is basically baroreflex activation therapy. It's goes on the carotid bulb, and it essentially is indicated for about 30% of HFrEF patients. And those are the patients that sort of they don't qualify for CRT. They're still in heart failure, and these patients CRT is not indicated. So this is when you implant this Barostim device. You put an electrode on the carotid bulb, and it basically more or less is activated, and it stimulates the carotid and then decreases the sympathetic output to the heart and improves the overall heart failure symptoms. This is a treatment option for patients with NYHA class 2 or 3, with EF less than 35%. Those are the patients that CRT is not indicated. Barostim would be a optimal choice on these patients. So Barostim indications, NYHA class 3, a recent history of NYHA class 3, EF less than 35%, BNP less than 1600, not indicated for CRT or not receiving adequate response from existing CRT device. So this is basically electrode is placed in the carotid bulb. It's a little incision made by vascular surgery, and then this is a lead that's tunneled in. There's a little generator, and the generator sort of impulses and sends electrical signals to the carotid bulb, and then the sort of counteracts and rebalances the autonomic nervous system. It helps with the overall heart failure symptoms and heart failure treatment. So this is the electrode tunneled in, and then this is the device that sends electrical signals. It's implanted on 1 hour as an outpatient procedure in the OR or hybrid OR. It's safe and efficacious. And looking at the overall studies, medical management versus Barostim plus medical management overall, it's a 6-month follow-up, showed overall benefits of Barostim as far as the quality of life, exercise capacity, and NYHA class improvement of patients that receive Barostim versus optimal medical therapy alone. There was also a 10% reduction in the BNP in patients with significant benefit in terms of cardiovascular death and heart failure hospitalization. This is basically the exposure of the skin and the carotid bulb, and then the electrode implantation, tunneling of the leads, and then the generator, which leads to the impulses to the carotid bulb to counteract the sympathetic overstimulation of these heart failure patients. CardioMEM device is basically, it looks like a little memory chip or flash drive. It's actually implanted in the branch of the pulmonary artery, and it more or less detects changes in the pulmonary artery pressure, wedge pressure, and those signals are basically sent in electronically as the patient lays on a pillow, and the physician as an outpatient can monitor the overall changes in the wedge pressure. The Champion trial showed that patients that got the CardioMEM device and they were followed, their wedge pressures were followed, and their diuretics were titrated appropriately, were kept out of the hospital, and their overall hospitalization rates were lower because we were able to keep track of their PA pressure and wedge pressure changes on a regular basis and be proactive about their treatment. So the indications and usage, CardioMEM device is indicated for wirelessly measuring and monitoring pulmonary artery pressure and heart rate in New York Heart Association NYHA class 3 patients. So there was a 33% reduction in heart failure hospital admissions, 70% reduction in heart failure readmissions, 57% improved survivability, 53% improved survivability at average of 18 months follow-up. In conclusion, heart failure is a cardiac dysfunction that can be due to contractile dysfunction, systolic heart failure, or relaxation dysfunction, diastolic heart failure. Identification and treatment of New York heart failure is crucial to preventing progression and demise of the patient. Medication therapy includes beta blockers, ACE, ARB, diuretics, aldactone, ARNI, SGLT1 and 2 inhibitors, and then also the Verquvo, which basically activates the cyclic GMP, leading to vasodilation and relaxation and improvement of heart failure symptoms. Cardiac resynchronization therapy promises quality of life improvement for some patients with poor systolic heart function who have been maximized on medical therapy and yet are still symptomatic. And Barostim is beneficial in patients that don't qualify for CRT. So question 1, what is heart failure, the intermediate EF stand for? And what's the EF, I should say? And the answer is B, heart failure with EF between 41 to 49%. CRT is indicated in what percent of patients with heart failure? Answer is 30%. Question 3, NYHA class is a patient What NYHA class is a patient with cardiac disease, marked limitation of physical activity and fatigue, no dyspnea at rest, but dyspneic with minimal physical activity? And the answer is D, NYHA class 3. Thank you very much.